So we found the mass somehow. We scoped people, we had a symptom, we found something, and the next step is a biopsy. Maybe Chris, Dr. Heary, maybe you want to go into what that looks like?
Yeah. So, I think when people hear the word biopsy, their first assumption is that a biopsy is for cancer. I want to point out that a biopsy is a term that means taking a piece of tissue and then being able to look at it under a microscope and understand that tissue better. So biopsies can sometimes reveal that something is not cancer. They can sometimes reveal that something is an infection. So a biopsy is a really important tool when we are trying to understand what a mass is, what something that is not supposed to be there, what is it actually made of? So we can put a needle into that thing, and the size and the shape of that needle and how that needle gets there can be very different depending on where the mass is. So I maybe give a couple examples. If someone were to find on imaging, on a CT scan, a mass in their liver, that patient will most likely need to go to a special other kind of doctor called an interventional radiologist to get a needle into that mass, take a hunk of it, usually what we call a core biopsy, where you're taking a certain size needle, you're introducing it into the thing, and then pulling out, like a cylindrical plug, and then looking at that under the microscope. Now, if somebody has a breast mass, the doctor might be able to get a biopsy of that in the office if they can palpate it and get a needle into it. So very different things. Similarly, if you have a skin mass or a skin-looking tumor, you're probably going to see a dermatologist or a dermatopathologist, somebody who can carve that thing off and then look at it under the microscope. If somebody has a mass in their brain, you need a neurosurgeon.
I might add on the fine needle aspirate, or FNA. We throw around FNA. And you can sneak needles into places and get just a few cells from whatever it is. And the pathologists often can tell what the problem is just from those few cells that were sucked out of a small skinny needle. Gastroenterologists have a little micro, almost alligator clip-like thing that they can stick through their scope to wherever they see something in the stomach or in the colon and take a sample of it there. And then really the ultimate is when there's a big surgery. You're removing the mass. There's plenty of tissue there, but sometimes that is the first thing that happens. And so you might end up going for a surgery even before there's been this sort of biopsy.
So I want to give some context that when you wonder, why am I talking to so many doctors at the beginning of this thing? It's because each of us do one thing well. And truthfully, you don't want me trying to get a piece of your liver mass. That's a bad idea, right? And similarly, you probably don't want the interventional radiologist deciding on your chemotherapy or your immunotherapy or whatever it is, right? So each of us study very specific things in order to do things. And so there are certain tumors that sticking a needle into it actually increases the risk that it might spread along the track of that needle and actually worsen the likelihood of cure or long-term disease control. It's a very select number of tumors that for which that is true. So essentially, you would very rarely go for a biopsy if that could be cut out surgically. You would just go to surgery because anything taking up that much space needs to come out anyway.
You have this biopsy, you have something under a microscope. They take a piece of the tissue and the pathologist, another physician, you'd never probably meet your pathologist, by the way. The pathologist takes great care with what they receive and get it into a situation where they can now study it. And usually that means putting a sample of it on a really skinny sample of it on a glass slide and looks at it under a microscope. Sometimes that's done while you're still having your biopsy in something called a frozen section, so that the surgeon knows right away exactly what they're dealing with. It's not as good a look that the pathologist can make with a frozen section as they can with a permanent section. Most of the time, we don't do frozen sections. It can take days. to do all of the preparation that is needed on that one sample to make sure to give the proper reading, to analyze the cells, to determine, and our next set of words, is this benign or is this malignant? Is this not cancer or is it cancer? It doesn't necessarily mean it's cancer. It's just a growth, something that's growing. So you probably have a mole somewhere on you that will never turn into cancer, but it's growing, right? You look under the microscope at those cells, they're benign, meaning they're growing, but they're not going to spread somewhere. They might get larger over time, but by themselves, typically benign things don't cause too much trouble. They can take up space, they can get in the way of other organs, but typically they're not things that will ultimately kill somebody. Malignant, on the other hand, is cancer. And that's where our pathologists come in to really look at the cells under the microscope, see if they have the characteristics of a malignant cell, a cancer cell, and they can tell. That's what they're trained to do by the appearance of the cells. Sometimes it's in between. We get these sort of hedge bets, if you will, because there is a transition that benign things can become malignant, right? And so say a benign polyp in the colon, we know that some cells within a polyp could become malignant and be the beginning of colon cancer. We monitor people a bit differently.
I'm going to add a few things just that I know I've heard come up from family members or friends when they're trying to understand pathology reports. I have heard people commonly say, oh, my friend has liver cancer, when in fact they have colon cancer that has metastasized to the liver. Or, they have bone cancer when they have prostate cancer that's gone to the bone. And I think that is a very confusing topic. We're going to come back to the word metastasize, but all it means is going to a different part of the body than where it started from. What it means is that the cell type from which that cancer cell started behaving abnormally is normally X organ or X cell type. How do you know that something is a colon cell or a lung cell or a skin cell? They can just look at a cell and go, that's from this part of the body. It's still amazing to me how good they are. And they can then add on other stains on top of that. So what I mean by stain is there are techniques they can use that will highlight different parts of that cell and say, this is unique to this kind of cell type. And go, oh, this one is clearly from the liver, or this one is clearly from the colon or from the lung or from whatever. So something can be from the lung, for instance, and be an adenocarcinoma, or it can be something called a small cell lung cancer. And those are actually different types of cancer with different outcomes and different treatments, but they come from cells that live right next to each other. So when they end up in a different place in the body, it's still a lung cancer. It just is a lung cancer that's moved to somewhere else. The reason you get the biopsy is that these people that look at that, the pathologists, can tell 95% of the time where that cell came from, what its behavior is likely to be, and all kinds of features by looking at it under the microscope and staining it different ways. So it's really important that you get that information early on.
So we go from you have a tumor now that we know it's cancer with the biopsy, and the next sort of language is around trying to figure out what category you fit in, what subgroup group you fit in.